Good morning, everyone. It's such a pleasure to be here this morning in front of you all. And I'll be speaking on the surgery for epiretinal membranes and showing you different situations for the same. So an epiretinal membrane is typically idiopathic, and the most important risk factor is age. It can also be secondary to retinal vascular diseases, uveitis, trauma, retinal detachment, or laser. Now, before taking up a patient, the patient's visual acuity and metamorphopsia are the two important factors that we consider. And the OCT picture does guide us in planning the surgery and also in prognosticating, wherein we look at the outer retinal layers, most importantly the ellipsoid zone. The OCT can also help you in your surgical planning, whether to see the configuration of the membrane, whether it's globally adherent, loosely adherent, and also tell you about the planes of separation. Now, before taking up any patient for surgery, a very good pre-op counseling is extremely important. You have to tell the patient that the vision and the metamorphopsia is not going to improve immediately after surgery. Most patients can expect a 2-line improvement, but generally it does come in after 6 months, and generally the vision sometimes goes on improving even up to an year. Poor preoperative vision and long duration of symptoms have worse visual outcomes. The surgery is standard. You do a pars plana vitrectomy, induce a PVD, stain with dyes, and then do an epiretinal membrane peeling or an ILM peeling if required. The two dyes that have really helped in this surgery are the trypan blue and brilliant blue. Trypan blue selectively stains the epiretinal membranes. It is of a higher concentration than that used by cataract surgeons. And brilliant blue dye selectively stains the ILM, and we can make use of these differential properties while we are doing the surgery. So I'll show you some situations. What I talked about was for idiopathic membranes, but I'll be showing you some secondary membranes. So idiopathic membranes are generally avascular, but this is a vascularized epiretinal membrane following a branch retinal vein occlusion. This florid vascularization, the laser was done and the vascularization went down a bit, followed by an anti-VEGF injections, and you see the thick membrane there pulling up the retina. So some epiretinal membranes can come off while you've induced PVD itself. They can come off with the hyaloid phase, as in this one. It did seem like a very adherent membrane, but it simply came off while I did the PVD induction. And this is the post-op patient. There is some residual subretinal fluid, so this fluid need not be drained. It does absorb over a period of time. This was an unusual membrane. It's more like a thickening of the hyaloid face here. A very thick membrane present right at the center. And again, this membrane came off very easily while inducing the PVD. You see how thick this is. And this is the post-op result. So so you have to watch out whether your membrane has come off with the PVD induction or not. Now the surgery for epiretinal membrane is pretty simple and standard. The technique most often followed is a pinch and peel technique. You do not have to use any picks or MVR blade to find the edge. Now that we have dyes, the edge is very easily found. And you can simply go to the edge of the membrane. If you cannot find the edge, you can simply peel the ILM at the edge of that membrane, and then the membrane comes off easily. You move in a tangential manner. Now, some other caveats during surgery are, so here again, the pinch and peel technique. It may take a few tries. So you do it in an area away from the foveal center. And this is how you roll back the membrane on itself. You do not pull in the anterior-posterior direction. You go circumferentially, just like a capsulorhexis, so that you do not damage the foveal tissue. And if you feel that the peeling is not possible from one direction, you can always come from the other direction. So this is how it's done. Do not pull in the anterior-posterior direction. You can always restain the membrane and see. So that's a very good idea to restain. This is a diabetic membrane here. So you see the edge is very easily identified. There is some retinal whitening as these very tightly adherent membranes in diabetics, and sometimes that can be mistaken for an epiretinal membrane. You can always stain again to identify the edge. This is an epiretinal membrane in a vascular occlusion. So an extensive membrane on the macula extending even beyond the arcades. The edge is visible here even without the stain, but the stain really identifies it very well. So you simply take this and again move in a tangential manner. In these vascular membranes, it's very important to keep an eye on the other side of the membrane. So you see here one edge is attached to the disc. So you have to be very gentle in your peeling so that you do not pull and induce profuse bleeding at the disc. Now you see that talking about ILM peeling, cases like this which have a lot of internal limiting a lot of folds on the retina here. So these are the cases that you should do an ILM peeling along with the ERM peeling. Also, idiopathic membranes generally would not require a concurrent ILM peeling, but secondary membranes like post-uveitic, post-vascular occlusion, it's a good idea to do ILM peeling along with the ERM peeling. So you can use just one of the dyes, and this is something called the negative staining of the epiretinal membrane here, where the dye has only stained, the video is not working. Okay, the dye has only stained the internal limiting membrane and not the epiretinal membrane, and the negative staining can help you in peeling off the membrane. Sometimes, like I mentioned before, it may be difficult to find the correct plane. It may be difficult to identify the epiretinal membrane, as in this case, the macular hole case. This is the epiretinal membrane, but I'm not sure how this is going to be attached to the fovea, whether I'm going to damage the fovea or not when I'm pulling this membrane. So the ILM away from this membrane is peeled, and as you peel the internal limiting membrane, the epiretinal membrane comes off along with it. So this is a very good technique in cases of very adherent membranes. You can just peel the ILM away from the epiretinal membrane and the membrane comes off along with it. Post-uveitic membranes, as you can see in this video, are sometimes very tightly adherent. They are more elastic, and you do have to apply quite a bit of force to peel off these membranes. They are very rubbery and elastic in texture. These membranes, again, tend to recur more often. So again, like I said, an ILM peeling would be good. Again, you see the direction. You have to fold the membrane on itself and not pull in an upward direction so that you do not cause any pull on the retina. For membranes like this is a combined retinal detachment. You can find the proper plane of cleavage, the proper tissue separation plane at the disc. So you can pull this membrane with a forceps at the disc itself. Since the retina is very thick in the peripapillary area, there are very few chances of inducing a break. So once you've got this membrane off at the disc, you can use a cutter to then remove this membrane. For diabetic membranes, generally the cutter works very well. Now that we have the 27 gauge cutter, it can go under these membranes, you can segment, you can delaminate, you can segment, and you can go really close to the retina, you can go very close to these vascular pegs and cut off the membrane very safely. So the cutter itself does the job very well. Again, you can use an inside out or an outside in technique depending on the case. So you have to tailor your technique to the case. In this case, I was apprehensive that if I started at the disc and made a tissue separation with the forceps at the disc, I would have profuse bleeding. So that is why I'm using this coming from away from the disc and coming towards the disc so that I do not pull at the disc tissue at the disc and cause bleeding. Here you see this vascular peg. This tissue is attached to this vessel here. So very gently you have to separate it off. Also the membrane has extensions at the posterior pole. You can gently tug at it and see the attachments. And here you see with the cutter itself, you can get the entire membrane off. So you should keep your suction a bit low at this time so that you do not inadvertently get the retina into your port. So that's the end of the surgery. So again, showing you segmentation in another diabetic patient, similar. Now, in retinal detachments with PVR, it's very important to find...
Doctor,
yeah,
take a questions
okay,
on this
fine.
page.
Yeah,
one
you.
question. Excellent videos. I would say, what's your take on this classification of epiretinal membranes and based your surgery on AIFL and probably operating at an earlier stage of stage 2 when the AIFL is just formed rather than letting it go and to form a macular pucker and disorganization of the retinal layers.
Yes, I know. There's been a lot of papers coming out on this AIFL. I personally have not looked at these biomarkers in my practice since these studies have recently come in. But yes, if you do follow up, there would be a subset of patients who would stay very stable over the years, and there would be a subset of patients who would show progression on the OCT. So it's not just the OCT, you keep the patient's vision and the symptoms in mind and then decide to take the patient up.
Dr. Martin, I think it would be better to operate at the stage 2 when the AFL have just formed rather than wait for it to progress.
Absolutely, and actually that was going to be my question is, all the case examples that you've demonstrated here are beautifully operated on, but they're all quite advanced membranes, and I think the big controversy about ERM surgery is on the other end of the spectrum, is what do we do with the milder ones? At what stage should we offer surgery, and in what sort of timely manner should we be doing those surgeries? So what's your take on kind of a different type of patients, for example, where vision is still pretty good, 20/25 6/9, they got mild metamorphopsia and the OCT has a mild ERM. What do you do in these sort of cases?
So I would leave it to the patient's decision. If the metamorphopsia is really bothering him, then I would definitely ask him to go in for surgery, provided he's willing. Also would look at other factors, his lifestyle, his visual needs. With a patient with 6/9 vision and mild metamorphopsia, I would not push the patient. I would ask him whether he requires the surgery or not.
Yeah, I mean, personally, I look for evidence of progression. So I would see if the patient's vision is deteriorating, if it's symptomatically getting worse, or if the OCT is progressing. Those cases I would maybe do a bit earlier. Any comments from the floor on that topic? Okay, then maybe we'll move on.
Thank you, Dr. Tinku, for excellent talk. Now